is so much bigger than anything you will face today. Leave everything in his hands and embrace this day, confidently knowing that he will take care of you.
Amen.
Amen. Yeah, anytime you got today. Usually fits something. I really like that. Any prayer requests this morning? Yes. Silent. I'm sure there's lots of those. Okay, we'll go ahead and have prayer. Loving Heavenly Father, thank you for another beautiful day. Thank you for life. Thank you for each one of these students being present despite being exhausted and pushed. And please give them energy for the rest of the quarter. Give them clear minds and help them as they start putting all the information together that they're getting in all the classes to make sense as a variety of topics that come down to being able to treat their patients safely, and be with every silent prayer request here, and just bless them as they go into their afternoon. Thank you for hearing our prayer in your name. Amen. Okay, turn away your phones. Any questions about that might put you to sleep. That's your, so hepatitis C, what might the 2 stand for? Think about it. Two uppercase letters. H, hepatitis C.
Okay, let's go over that really quick. Okay, hopefully these couple of questions based on the reading you could have figured out from your previous knowledge, but we'll see if according to the study investigating the risk of aspirin and bleeding, the ABA agreed with their conclusion that aspirin or Platelet therapy should be continued in patients who have coronary artery stents due to the thrombotic risk of discontinuing therapy. We never discontinue therapy anymore. That's very dangerous to do unless the doctor is working with you, and we don't ever suggest that or do that. We'll actually talk about it in that study. Coumadin is an anticoagulant therapy used as a blood thinner for CVD. Is that true or false? True. A dental patient on Coumadin who has an INR value of 4.5 is within normal range and should not be a cause of concern. Good. Okay. Elective dental treatment should be postponed on a patient who notes on their health history that they are a chronic carrier for hepatitis B. False. What if it had said acute or active? Okay. Which of the following forms of hepatitis pose the greatest risk for occupational exposure? A, C, D, or E?
Washing hands.
That's a good one for another answer. Okay, she said washing hands. Okay. The answer was C. That was in your book. That was a review question, but hopefully our conversation last week in class made that clear that C is really our only one that we're going to worry about. However, if you were poked with a needle or cut yourself with an instrument or poked yourself either, with a hepatitis B patient, we would still send you to get a titer and to decide whether you would get a treatment. And now I'm reading more and more that it may not last forever. They don't know for sure. So like I had mine so long ago that especially if I got poked with a patient who had hepatitis B, I definitely would want a titer and see if I needed treatment or not. So maybe they'll come out when you need a booster with Hep B, but right now there isn't an exact time frame. So just remember that. So we don't want to just look at a hepatitis B patient and kind of dismiss it. Now, not very many of them are carriers. Do you remember the percentage of hepatitis B that remain a carrier? 10, yeah. So that's a lot different than Hep C at 85%. But if you get poked with somebody with hepatitis B and you haven't seroconverted or you didn't have the vaccine, what's the approximate percentage chance that you would contract or become infected with Hep B?
20 to 30.
Yeah, 20 to 30. 85 is the, we'll talk about 85 in a moment. Okay. Okay, if concerned with post-procedural pain for the patient with chronic hepatitis, it is important to take into consideration that there may be unpredictable metabolism of certain drugs. Is that true or false?
True.
acetaminophen would be considered the best choice of pain reliever. That's false, because it's acetaminophen, we talked about that last week. It's a one-time, it's actually processed through the liver. That's why we worry about the liver when people take excessive acetaminophen.
But was the last question regarding the elective, is that true or false? I didn't.
Oh, that was back a while. Let's see, elective, oh yeah, that was, false, because it was a chronic carrier. Okay, here's your question, Bannon. Okay, Bannon gets to answer this. What is the best way to break the chain of transmission of hepatitis A?
I want to go with washing hands.
Washing hands, for sure.
Would all, like, 3 of those be right though? Washing hands.
Well, it's not spread by blood,
Yeah, that one.
okay? It's not spread generally by sexual transmission. Wearing a mask, that's probably a good idea. But what was the best question, answer? I mean, we had it in the PowerPoint and the, so what did you choose?
The mask versus oral.
Okay, okay. Okay, that definitely, if they were actively, but, okay, so I didn't say, what is the best way to break the chain of transmission of hepatitis A? That's more in that, what I meant, so maybe I should add that to that question, is when you're out, and it not necessarily occupational, all of those would mix, but just washing your hands if you went on a mission trip or anything, so, yes.
Well, isn't A transmitted to like feces?
Yeah.
So not just A in my mouth. Or
Well, oral fecal.
Oral.
Yeah. So whether it's airborne, I'll look at that because that'd be although it's fatter, but so I'll look at that. But I should add, I'm thinking in the general population, how is the best way to stop it? And that's definitely by washing your hands. Just simply that's the best stop of transmission. Okay, this is a little tricky one. Hopefully, this is true, false, or true, false. Acquired active immunity is artificially acquired by inoculation of protective antibodies such as hepatitis B, immunoglobulin, after a stick injury, whereas acquired passive immunity, those are the key words, active and passive, is acquired when given the vaccine with some antigens and the body is required to make the antibodies. False. Yay!
It had to be switched.
Okay. Which type of hepatitis, A, B, C, D, E, have immunizations available? ABD. I mean, or if you put AB.
Because B technically covers C, right?
Yeah. Which of the following types of anemia is associated with an inherited defect of the red blood cell anatomy and a defect in the hemoglobin within the cell? Sickle cell. That was a review question, plus you probably knew that. I had a harder question. You probably knew that from previous anatomy and physiology here somewhere. Okay, here's the last one. This is where the two came into. If you were to have a contaminated needle stick while treating a patient with chronic liver infection from Hep C, what is your approximate percentage of risk for contracting hepatitis C?
1.8%.
Okay, 1.8 if you're detailed, like AJ, and estimated is 2. So I will accept either of those, okay? And what is the percentage chance of a patient with Hep C likely to have chronic infection with Hep C? It's a big one. 85. That one's 85. Oh, I'm sorry. Every year it does get so confusing, but if you understand, then you understand your risk. Okay, so basically, And I was thinking that maybe before next week, we need to make, maybe I'll make a chart of all the important numbers. Because these three have a lot of important numbers, these three lectures. It's a lot of numbers, I know. Hep C, you only have a 2% or 1.8 to 2% chance of contracting the disease if you have a stick injury. But hepatitis C, anybody who's been infected with hepatitis C, the patient or whoever has it, has an 85% chance of having chronic infection. That's why we worry about them so much. It's almost everybody who's ever had hepatitis C is a chronic carrier. So like Hep B, and I know, only 10% of them are chronic carriers. But we have a 30% chance of getting it. So if all those numbers interact, but Hep C, that's why even though we have a low, 2 in 100 would get, if all 100 people poke themselves, 2 of those would get Hep C, only 2. That's encouraging. But almost every patient you treat with a history of Hep C is an infected carrier, or a carrier of infectious disease. Does that make sense?
Yeah, I confused it with the cirrhosis, 20-30%.
Yeah, that's Hep B, and you're right on that. Okay, well, I need an extra credit question, don't I? I'll have to think about that. Maybe on the, okay, know that for next week, okay? And know, what is HIV? What's your chance of getting HIV with a puncture wound? 0.3. So we've got risk of 0.3 HIV, Hep B 30 approximately, and Hep C 2%. Those are your risk factors. The only reason I really want you to know that 85% on Hep C is because I want you to know that almost everybody you treat is going to be a carrier, and you are at risk. And you're going to slow down and not poke yourself with anything when you're working on a Hep C patient. Okay? If you take that from this, and you just remember that because you missed this question, and maybe I give you extra credit later, just remember, Hep C, they're most likely a chronic carrier of the disease. So if you poke yourself, fortunately, you only have a 2% chance of getting it, but they're most likely infected until they all get it eradicated from the new medications. Does that kind of compute, Ben? Will you take that out of this at least? Okay. Okay, so know that, especially know the numbers on Hep C. And then the comparison between Hep B and HIV, I love that one. The 0.3 versus 30%, because I also want you to know that you don't have to be terrified of treating a patient with HIV. It's really not as scary as some of these other things. So, okay, I think that was it. 0.3, yeah, 0.3. Okay. Okay, so I've got to keep your attention today. I'm going to try to make this as simple as possible, or this could be crazy. If you took a hematology course, it'd probably go for a whole year. So I'm going to try to tell you what you really need to know, and we'll watch. We don't have that much time, so we'll watch a few videos to help you try to remember it, and you can always watch them on your own. But I know you don't have time, and you probably won't, but if you're interested, you can. So we're going to basically talk about the most common bleeding disorders we might encounter. We've talked about bleeding quite a bit, so this kind of brings a few other things into it, but it also will be a little bit of a review. How we prevent it or manage bleeding, and if signs that we might see on a patient that might tip you off before you even start. If you see a big bruise, just the other day, I don't know, it was with the juniors or the seniors, so I saw a gentleman big flat grooves. Is that yours? Yes. Ecchymosis is called. You're going to learn that term. But the other thing is called petechiae, and they're little pinpoint red dots that could be present in the palate. So if you see that, you're automatically going to assume this patient bleeds easier. And this is really key. If you're going through the health history and you ask if they have any bleeding disorders, they go, no, I don't think so, but I get nosebleeds a lot. Then that means they're more likely to bleed in your chair or bleed after they go home. So remember that nosebleed. If somebody brought that up, or if you ever were worried, ask them if they get nosebleeds very easily. Yes.
Doesn't heat have to, it doesn't, like, overheating involve nosebleeds? So would that still be considered it?
Yeah, I mean, there's different things. I got a lot of nosebleeds when I was a child growing up in Prescott, Arizona, because of the dry, high elevation. It's all we could think of. I mean, I just all of a sudden just gush, and I don't have a bleeding disorder. So
Okay.
there are other causes.
Okay.
But if you have some questions and the patient says, oh yeah, it takes me a long time to heal after I cut myself, or not heal, it takes me a long time to quit bleeding. So you'd have to put that all together. But certainly that's a good point, is that nosebleeds don't always mean they have a bleeding disorder. Okay. Okay, a few lab tests. You already know about the INR, so we're going to talk about that and treatment modifications for these patients. A bunch of great words. Epistaxis, that's nosebleeds. You'll probably see that again. So be able to connect that with a nosebleed, because sometimes they use those words instead of the common words that we're used to in a question. Okay, so basically bleeding disorders are conditions that alter the ability of the blood vessels, platelets, and coagulation factors to maintain hemostasis. What do you think hemostasis is?
Clotting. Normal clotting.
Normal clotting. Chemo and stasis controlled, stable. So often they'll do this, they kind of estimate a practice of 2,000 people, and you could have 100 to 150 patients. I'm going to show this. Now this is in your assignment. To me, this kind of explains a lot of the disorders we're going to talk about. So if you think about, what do the platelets do? What do the blood clotting factors do that are different? Because that's what the different medications work on. Platelets, antiplatelet is like aspirin and Plavix. Anticoagulant, so your clotting factors is warfarin and Coumadin. So watch that, because those are different, and that will help you remember which is which when you're asking for an INR. Because antiplatelets, INR won't tell you anything about the antiplatelets. It only tells you about clotting factors. So think about the platelets in this, and think about the clotting factors especially, and kind of watch that. And I think that will help you. Did you hear any sound?
It's new.
At the bottom left,
Video.
the little sound dots.
Maybe unplug that.
Oh, yeah, it is. Okay.
Is so important. Your blood clots to stop the bleeding. Clotting is a complex process, and there are four main things that make it possible. Platelets, or cell fragments, clotting factors, which are special proteins, fibrin, which is a protein mesh made up of a special kind of clotting factor, and finally, other cells, like red and white blood cells. Because clot formation is so important, platelets and clotting factors are always available, floating around in your blood. Now, let's talk about the 4 steps involved with forming a blood clot. When there is a tear in a blood vessel, The first thing that happens is that the nearby platelets are activated and become sticky. They start sticking to each other and to the sides of the hole in the blood vessel. For small holes, enough platelets usually stick together to form a temporary plug. But a platelet plug isn't strong enough to block the opening for long, so it must be reinforced with other materials. Otherwise, the blood flowing past the hole could wash the plug away. These other materials are called clotting factors. As the clotting factors float by the tear, they become activated or turned on and add themselves to the platelet plug. A special kind of clotting factor can weave itself together with others of the same kind and form a web of fibrous tissue called fibrin. This web acts like glue and holds the platelets and the other clotting factors together, creating a blood clot. Other cells, like red and white blood cells, can also get caught in this web and help reinforce the clot. It quickly becomes stronger and starts to pull the edges of the hole in the blood vessel together. After the clot has formed, it stays in the hole until the tissue is repaired. When the clot is no longer needed, your body dissolves it. Tissue is repaired. Tissue is repaired. When the clot is no longer...
Okay, starting to dissolve right there. But to help you think about what could happen cardiovascularly, when people have arteriosclerosis, that's clot inside the vessels, a piece tears off, becomes an embolism. Remember, the emboli move through the blood vessel. Then a clot is going to form where that piece of plaque tore off. That's what becomes a thrombus. And it's good, our clotting system is good until you have a vessel that's already really narrow, a piece of plaque breaks off, and then it forms a bigger thrombus, or almost like a scab inside the vessel. Then that can actually be problematic because it restricts the vessel even more. So does that make kind of help you with the thrombus idea and the embolism, and then why breaking off a plaque could actually, either way, the piece of plaque could clot it, or the clot that forms over the broken area or the torn area could restrict the vessel. So either way, you could have a stroke or a heart attack. So that kind of makes me think it kind of fills up that space until it dissolves. So, and that's why sometimes if you're having a stroke, they'll give you an anti-thrombolytic agent to actually break up this clot that's filling and protecting that area. And it's what our body does to help us can also be damaging if we're not healthy, if our vessels are full. That hopefully makes sense. Okay. So that kind of helps us just focus in, zone in on what can go wrong. So we're going to talk about platelet disorders. So the platelets that first go into the tear. Coagulation disorders, so that's the clotting factors. Liver dysfunction, the reason liver affects it is the liver makes clotting factors. And then some things, drug-induced clotting abnormalities, which we've talked a lot about already, so it'll be a nice review. I am just going to show this to you, and then we'll probably really go after that. But
inherited bleeding disorders are serious conditions that impact the daily lives of millions of men, women, and children around the world, their families, and their communities. During this video, we'll learn more about the many phases of bleeding disorders, including Hemophilia A and B, symptomatic carriers of hemophilia, von Willebrand disease, rare clotting factor deficiencies, and inherited platelet disorders. In a healthy person, bleeding starts when a blood vessel is injured and blood leaks out. The blood vessel tightens up to help slow the bleeding. Blood cells called platelets make a plug to patch the hole. Next, many clotting factors, which are part of the blood, work together to form a clot over the plug. This makes the plug stronger and stops the bleeding. People with bleeding disorders have deficiency or dysfunction of clotting factor or platelets, resulting in inability to stop bleeding when injured. Consequently, the clot they form is weak, and bleeding goes on longer than normal. Bleeding stops when the deficient or dysfunctional clotting factor is replaced.
The prevalence of haemophilia is about 1 in 5,000 male births. It can be a very serious disorder in its most severe form. Hemophilia A is a deficiency in clotting factor 8, and Hemophilia B is a deficiency in clotting factor 9. Hemophilia is an inherited condition. It's carried on the X chromosome, so it's traditionally passed down from a mother to her son. But in about 30% of cases there isn't a family history, and it seems to occur as a spontaneous new event. These individuals are prone to develop bleeding into their joints and muscles, starting at a very early age, and if this isn't appropriately treated, it can result in long-lasting damage. At the moment, there is no cure for haemophilia, but we do have very good treatment available to replace the missing clotting factor, but 75% of people with severe haemophilia don't have access to appropriate treatment.
Hemophilia has had a pretty severe effect on my body. I'm 24 years old and I need a knee replacement. I have pretty bad arthritis in certain parts of my body and target joints as well. So some days I have to deal with a lot of pain and it can be quite a struggle. To take care of hemophilia in my everyday life, I need to eat right, exercise, take my factor concentrates, know my limitation, and I need to have regular visits with the hemophilia treatment center. Although hemophilia poses its challenges for me, I'm still able to lead a relatively normal life.
While hemophilia primarily affects men, women who have the hemophilia gene are called carriers, and they can pass the gene on to their children. Though most carriers will be asymptomatic in day-to-day life, some may also experience bleeding complications, including excessive bleeding during menstruation, childbirth, and surgical intervention.
I found out that I was a carrier at the same time that we had a diagnosis that my son Paul has hemophilia. Looking back, I guess I did have prolonged bleeding and probably more bleeding than other people. I wonder about some of my own symptoms as a carrier and maybe why I didn't pay a little bit more attention to them. But I think most mothers of people with a bleeding disorder concentrated so much on what was happening to their son that some of their own problems certainly seem very trivial. And I think nowadays we're beginning to talk about some of the issues that symptomatic carriers have. So it's important for people to educate themselves and stay connected with their treatment centers.
While only women can be symptomatic carriers, both men and women can have von Willebrand disease. Although it is the most common inherited bleeding disorder in the world, only a small percentage of people living with it have been diagnosed. Like symptomatic carriers of hemophilia, von Willebrand disease is difficult to diagnose, particularly in women. Many people with von Willebrand disease have few or no symptoms, and women might not know they have von Willebrand disease until they experience complications in childbirth or after surgery. In fact, typically it takes nearly 16 years on average for a woman with von Willebrand disease to be diagnosed.
I was diagnosed with the von Willebrand disease type 3 when I was 2 years old. I have very strong and heavy gum bleeding, joint bleedings, and strong menstruation, menorrhagia. I wasn't able to have the same life like my sister. And now when I get a good replacement therapy and physiotherapy, I have only a little bit of gum bleeding. Now I have my hobbies with reading books and go for cinema and go shopping, and to be with my family, it's great for me.
Rare clotting factor deficiencies are bleeding disorders in which people are missing one of the factors, or these factors aren't working properly. Less is known about these disorders, as many have only been discovered in the last 40 years.
The rare factor deficiencies can present in mental
and have faced many physical and emotional
and bleeding of all different sorts that presents often very.
Okay, we just, I'm gonna move on, but that gives you a little idea of the difference. Remember that picture of the little boy with his knees really enlarged? That's hemophilia, and that will help you remember some of the symptoms that go with it. we're gonna have a question later on, so hopefully I'll get that. Okay. And we're also gonna do blood-related abnormalities, which is anemia. So we'll start with platelets. You saw the platelets, and they're formed in the bone marrow. And they're also, you saw, they're the first ones to come to a tear or break. They, along with the clotting factors, spin that web, and they're involved in what they consider primary hemostasis, so stopping of bleeding. So thrombocytopenia, and such a big word, but if you know that platelet, the medical term is thrombocyte. There's something wrong with the thrombocytes or the platelets. Either there's not enough of them or they're damaged. And so that's usually when we have a platelet disorder. Then you'll probably see these numbers again, so you have them in your assignment. But normal is 140 to 400,000. We actually can treat until we get down to about 50,000. So it's that just, yeah, that's important. Also, it's associated with leukemia because that's part of leukemia is in the bone marrow, so it affects the platelets. What happens is the cancer cells overtake the platelets cells and also attack them when they're being created in the bone marrow, and then liver disease as well. So basically, we can treat most people with who are above that 50,000 mark. How would you know that? We'd have to have had recent medical labs done, and unless somebody, usually they're going to know if they have severe bleeding problems if they come in. But again, if you just understand the process, it will help you ask the correct questions. Of course, anybody has a problem with bleeding already, we're not going to add aspirin or NSAIDs because they increase your bleeding. Again, petechiae, ecchymosis, all the signs of having a bleeding disorder. What they can do, if they know for sure somebody has low platelets, is they can give them an infusion of platelets prior to treatment. So if they have an actual platelet disorder, thrombocytopenia, and we're working with a doctor and they really, really needed treatment, some kind of, or they needed, say, an extraction or a whole mouth, or a whole upper arch extraction, then they could give them an infusion ahead of time so we could actually go ahead and treat. Then there's some local rinses that you can also use, and we'll talk about that a little more. There's some more pictures again of what the petechiae would look like in the mouth, and also the ecchymosis. And that you're going to see a lot of that, like Hannah did on her patient yesterday, with on their arms and all. They have different causes for bleeding disorders. Are you willing to tell them what happened yesterday? With I want Hannah, we're going to just stop for a moment because this was a perfect example of a patient not sharing all the information about their health history, and it just kind of came out. So I'm going to let Hannah tell.
Do you want me to talk about the bruise, or do you want me to talk about?
Tell them it's kind of off subject, but it was the same patient. So I just want her to tell you what this patient had in 2017, and he had some other things, but it wasn't on the health history, and he's been seen in the last 2 years. Okay.
So he had
louder.
He had a quintuple bypass surgery in 2017, and he was currently taking blood thinners because he needs that to prevent clotting and stuff, or anything getting in his arteries. And we were just talking to him about it, going through his health history, and then he mentioned, oh yeah, and they put a pacemaker in. And that wasn't anywhere on his record at all.
No, what he proved, I mean, that's correct. Yeah. But he also said, oh yeah, and he said something about AFib. Is that a thing? That's what he said. Is that a thing? And I go, oh yeah, that is a thing. That's called atrial fibrillation. Tell me about it. And then he said
He whacked it, then
he had a pacemaker and a defibrillator put in, both of them. So he probably had tachycardia of some sort. Well, and he needed AFib, that's fibrillation. So they had to have a defibrillator placed. So he has two of those, the one that slows down the heart and one that stops those crazy electrical impulses. Hadn't even mentioned him on anything else. And so it's just a good example of how there can be a major piece missing and his bleeding. What did he say anything more about
his hand on the way to the bathroom, and like within 2 minutes, like when he came back, he had a huge bruise, like really fast, huge bruise, really dark. So
and what
exactly
medication was he on?
Eliquis.
Yeah, he was on Eliquis, which is like Plavix.
How old was he?
He was.
He's turning 83 next month. Oh.
He was very cute. And his wife was down the road. But it was just fascinating. We looked at each other. I mean, we tried not to make it obvious, but we go, wow, that's a lot of information you hadn't shared with us before. So just interesting. Sometimes you get more out of those conversations. That's why if you understand and you're asking questions, that's, we were just commenting on the quintuple bypass and how he must feel a lot better now. And then he goes, oh yeah, and I had AFib, is that a thing?
So when you're actually in the work field and you don't, because most of the time from what I understand, you don't have time to talk to a patient much. And you miss that, and something happens, that would not be our fault.
Well, and that's why you can have those conversations relatively quickly. I mean, as you're feeding them, you're going through their health history, just a few comments. You can be, as you start maybe looking in their mouth and all, you can, but you're definitely going to review their health history. And you're right, you do have less time. But I hope that while you're here, you can become pretty efficient. Because you get faster and faster and you just feel a little more comfortable with asking questions. That's why knowing this stuff helps you to just kind of, and if you kind of know the process of, that's why I teach you what's normal, what's abnormal, what goes wrong, and then you have a little better understanding. Yes. But I agree, it's a problematic, definitely nothing. Yes, we were able to. We observed carefully. He's been in. He didn't bleed too bad. He had horrible oral hygiene. I mean, the plaque count was. I just told her, I go, you can go ahead and take it, but I'm telling you right now, it's 100% or 150. It could be, because it covered the whole tooth. I mean, it was very poor. So there was some bleeding, but it wasn't.
It wasn't a lot.
Too.
No.
Eliquis.
He didn't
Yeah.
take it that morning though.
Yeah, but he takes it at night.
Yeah.
So he takes it regularly. But usually the antiplatelets aren't as worrisome as the warfarin and Coumadin as far as heavier bleeding. But he definitely needs his teeth cleaned to keep him healthy, especially with heart issues. I told her he needs major OHI, anything you can get him to do. So, okay, back. So von Willebrand's disease, you got a preface to that. Basically, they're missing two factors. One called von Willebrand factor, and one called anti-platelet, or not platelet, sorry, a factor 8. So the von Willebrand factor actually makes the platelets stick together, and then factor 8 is just another factor that helps the clotting process. So with the combination of the two, they're more likely to have it. The problem is it's really hard to test for it, just like it said. Type 1 is the most common, and the bleeding levels aren't too bad. Usually, like it says, a female finds out when she's having, you didn't know Miss Heidi, she used to teach pre-clin up until last year, and her daughter had it, but she didn't find out until she left with the babysitter, and the babysitter called and said, she cut herself and I can't get the bleeding to stop. And then she kind of asked her mom and everything, found out her mom had it, never had known before. So it's usually more from symptoms than it is, except for if it's a severe form. Yes.
People are doing those like tests to find out like all the different things that they carry that they can pass on to their children. Is this something that will pop up on that?
That's a good question. I don't know the answer if this would, I mean, I kind of doubt it because it's so hard to even diagnose. They said it takes up to 16 years to diagnose it, but that would be a good question. I'd like, you know, I would imagine it would show up for hemophilia.
Mhm.
But it, you know, the genetic breakdown now, it's getting better and better, and it is a carrier through the mother that they drop down. So if they can start breaking down that gene that is problematic, then for this, they probably will be able to.
To diagnose, you wouldn't be able to tell off of like blood work. It would have to be the symptoms.
Yeah, that's what it has said about von Willebrand. Hemophilia is a little easier to diagnose. I should ask a hematologist. I'm going to see my brother-in-law this afternoon, who's a hematologist oncologist with my dad. I'll find out. So same kind of symptoms, any kind of bleeding. Girls often, they have extremely heavy menstrual periods, heavy bleeding after any kind of accident, or especially after surgery. Sometimes that's where they find it. There's another bruising, ecchymosis, just another picture. So basically, you should be able to treat patient within the office. Digital pressure works pretty well. Who was I working with the other day? Oh, a senior. And they had a lot of bleeding on an SRP down here. And so we just held it for a while with gauze, both sides, just some good pressure. And it decreased rather rapidly. If that doesn't work, then you are definitely don't want to dismiss that patient. If they keep bleeding and bleeding after pressure, after time, you don't want to dismiss them like that until we find out what's going on. That can be very serious. Okay, these two aminocaproic and tranexamic acid rinses are rinses, they call them anti-fibrinolytic rinses, which basically a fibrolytic, it makes a clot, so, or it helps break down a clot, I'm sorry, so it's anti that, it's exactly opposite of that. So it would help, they have these in offices to do that in case you have bleeding within an office. The desmopressin that we had talked about, that's something that's given prior to. So those are some things, those are medications, those three you should at least be able to recognize in a group. And yeah, if they had a severe type and they knew, then definitely we're going to talk to the physician. Okay, let's just, how are we doing? You know what, we only have 10 minutes. Okay, I'm going to go fast. There you go. This is, I kept mine in there. And that's from last time. Okay. And I'm not going to show that. So you had a little overview of that. It almost always occurs in males, but the mom or the female is the carrier. So it can be mild, moderate, or severe, depending on how much or how little that clotting factor there is. And that clotting factor is the same as von Willebrand's, in that it's factor 8. Okay, so yeah, if you get into genetics, I always find it interesting, the eye colors and the genes, who drops what and how many. There's a little explanation there, but I won't go into that now. Opposite of von Willebrand's, most people with von Willebrand's have the mild form. Hemophilia, the greater majority have the most severe form. Hemophilia B, she mentioned that too, that's factor 9. So it's called Christmas disease because the guy they first finally diagnosed, his last name was Christmas, and it came out in a Christmas publication in England. Just FYI, because I went, why is it called Christmas disease? That's why, just for fun. And don't worry about C, it's just one more type. Okay, again, now with hemophilia, you know, obviously spontaneous bleeding, but the big thing is bleeding into the joints and that swelling in the joints around the knees. So you just want to put that together with that. There's a picture again, like that little boy with the knee and just severe bruising. Definitely anybody with severe, we're going to do a med consult. And they're going to do either a platelet infusion or they're going to give some of the factors, the coagulating factors. Just like you saw in that picture, the people can live a pretty normal life if they know what factor is missing and they get infusions of that factor. So that's changed a lot. Obviously, that's in this country, not in countries where you can't get medical treatment. So there just kind of shows all the different types, but the two especially, A and B, which is factor 8 and 9. Okay, liver function, to just kind of understand again, normal function, the liver forms all the coagulation factors and the fibrin. When it doesn't function, obviously the number of those coagulation factors decrease, and it also affects the spleen. And the spleen gets rid of our platelets, and so it actually increases that activity. So it's a combination. The liver causes both the coagulation factors to decrease and the platelets to decrease. So both sides, pictures. Okay, those are different things that you may need for blood thinners. I know you guys are like full of all this good stuff, but just again, antiplatelet and anticoagulation, you want to know the difference because you don't want to ask your patient who's on an antiplatelet if they, what their INR is. Won't help you and they won't know what you're talking about. They'll go, INR, what's that? And then you'll go, oh no, they don't know their INR, I can't treat them. So know that it's basically on warfarin. One thing that's also interesting is they may do their INR if their liver function is poor, because again, it's a way to check the coagulation factors. So that might be another time they do an INR, but that's probably not going to be up to you, nor would you necessarily be getting all of that. But just know people with liver dysfunction, so hepatitis B, hepatitis C, any of the hepatitises could cause increased bleeding, because what does the liver form again? Fibrin, what else? Clotting factors, and it can cause the spleen to get rid of platelets. So it has 3 functions that are really important. So if you have liver problems, likely you're going to have bleeding problems. Heparin we'll talk about when we do kidney dialysis. I'm going to let you go back to that. So that study we talked about, 950 patients on warfarin were treated. Only 12 of them needed extra care for bleeding, but 5 patients experienced serious embolism formation. So they took away their anticoagulant. They formed emboluses or clots that moved, and 4 of them died. That's why we don't take people off of their anticoagulant anymore, or Plavix. It's easier to treat bleeding than it is to treat a stroke, heart attack, obviously leading to death. So just, if any of your dentists ever in the future, because there's some old school ones, because they used to think that, says, oh, we need to take your patient off of their warfarin or their Plavix or their aspirin that's prescribed by their doctor prior to you doing their SRPs. You go, let me just show you something and pull up something. It's even on the ADA website. I'll try to send you out with that on something, but don't let them do it. You don't want to be responsible for your patient's death because you're worried about a little bleeding that can most likely be controlled, okay? So there could be an older dentist that just isn't up on it. Okay, basically, oh, yeah, we got 1 minute, huh? I know you guys want to hear about anemia. Just know there's a few different kinds. The big thing about anemia is that it affects the red blood cells. And it's either a loss of production, they have less of them, or destruction. So my dad's been having a lot of really poor symptoms, and I called my brother-in-law yesterday, and he also told me he was anemic. And I started looking, as I was reading through this morning, I went, I bet that's a lot of his bad symptoms that we were really worried about. I mean, the cancer has returned and all, but anemia causes a lot of symptoms and a lot of problems, and it's pretty easily treated. So I'm actually hoping that we can get him treated for his anemia and decrease some of those symptoms. So that's just something you want to know, the different types of anemia. Pernicious, B12, huge. So I'm going to find out today if he needs some B12 injections. Might make for a big sickle cell. You can just look through there and look at your follow-up questions. There you go. Have a great rest of your day.
Thank you.
You're welcome. Yeah. What do you want to do? I'll just take it from Barbie's office and you just take it. I know, I told. I know, I can do it.